We'll hear now from Professor Shahid Khan, HCC and CCA, what can we learn?
Thank you, Heinz Joseph. Yes, just to swap in the talks, Professor Sharma's a bit delayed, so I'm going to give my talk first and carry on talking until she turns up. If I run out of things to say, I'll do a song and dance routine. Good morning, everyone. It's a pleasure to be here, as always. Thank you to Helen and the AMMF committee for organising this amazing conference and inviting me to give a talk. So I was asked to talk about HCC and cholangio. I see patients with HCC, I see patients with cholangio, and there are important similarities and important differences. HCC, as Abid has already said, arises from hepatocytes, the cells from the sort of meat of the liver, whereas cholangiocarcinoma arises from the cholangiocytes, the cells that line the bile ducts, this network of tubes that carries bile made in the liver to the gut. And Helen and the committee have asked me to give a really simple talk, which is talking about all the differences and similarities and all those things between the two cancers, each of which can have a 3-day conference on one of those on one of those aspects. So I'll do my best to see how we get on. But this is what I'm going to be talking about: similarities, differences, and these various aspects. So, what are the main similarities between HCC and cholangiocarcinoma? Well, as we've heard, HCC is the commonest primary liver cancer globally. So primary liver cancer arising within the liver itself. The liver is a very common site for secondaries, for other cancers to spread to breast, colon, etc. But in terms of cancers that arise within the liver, HCC is the commonest, and the intrahepatic version of cholangio is the second commonest. And perceived wisdom is that that's a small minority, 10-15% are intrahepatic cholangios, but I think that's not really true, certainly not in England. And around 10% of primary liver cancers seem to have features of both cholangio and HCC. Both have a high mortality if the diagnosis is late, and unfortunately in both cases the diagnosis often is very late. For both of them, the optimal treatment is early stage resection, ideally, but only a minority of patients are resectable at the time of diagnosis, and local regional treatments and immunotherapies now have an established place in both. And as Abid said, these cancers are increasing. In terms of diagnosis, there are some similarities and again differences. So with HCC, there is you've heard about biomarkers in this conference. Biomarkers are really important to diagnose and prognosticate cancers. HCC sort of has a biomarker, serum alpha-fetoprotein. It's not a great biomarker because about 30% to 35% of people with HCC, even advanced stage, do not produce AFP. But in those that do, it's a very, very useful biomarker. A very high level of AFP, normal levels less than about 12, but a very high level of AFP has important prognostic implications, plays a role in decision making, for example, with transplants. Whereas in cholangio, there is no, even if the AFP is not a great biomarker, we don't even have anything near that for cholangio. We use CA19-9, but it's a very, very non-specific biomarker, particularly in the context of biliary disease. Another important difference, interesting difference is HCC, you're allowed to diagnose without actually doing a biopsy. And this has been controversial, but for a decade at least, the global community has allowed HCC to be diagnosed in patients who've got cirrhosis if they have a typical features of arterialization with contrast and then washout in sequential imaging. There's a system called the LIRAD system now to standardize reporting, and you're allowed to diagnose HCC without a biopsy in many cases, which is really not true for any other cancer, maybe the odd pancreatic cancer, but really it's just HCC that's allowed to do that. And that's actually been a bit controversial because I think now more and more people are thinking actually, we should be diagnosing more as we learn about the differences between primary liver cancer and understanding the biology of tumours a bit more. With cholangiocarcinoma, you have to have histological confirmation because on imaging you cannot diagnose cholangiocarcinoma. A lump in the liver or a stricture in the bile duct could be cholangiocarcinoma, but it could be half a dozen other things. And there is no radiological definitive diagnostic way to diagnose cholangiocarcinoma. So you need histology or cells or cytology. But one of the challenges of cholangiocarcinoma is it can be very, very difficult to access that tissue, to find it or to reach it, because it could be in the depths of the liver, high up in the bile duct, where you can't actually reach it. You can't put a needle in to sample it. But then you're reliant on doing that, so you're in a sort of chicken and egg situation. You need to access it to make the diagnosis, but you anatomically, physically can't reach it. So, and there's no biomarker that is the equivalent, which is one of the challenges. So also in CCA, we often use endoscopic ultrasound or ERCP, which are invasive tests to access lesions around the bile ducts or inside the bile duct. And with cholangiocarcinoma, there's more molecular profiling, which you've heard about. I'll talk about more. When you diagnose a cancer, you have to stage it so that everyone is on the same page in terms of how advanced or non-advanced the cancer is, and that helps everyone decide on what the best treatment options are. The staging systems are quite different. So for HCC, in the Western world, less so in the Eastern world, but in the Western world, we use the Barcelona Clinic liver cancer staging system, which is sort of quite unique in terms of staging systems, because in HCC, most patients have chronic liver disease, so you can't ignore that fact. And that does limit or nuance your treatment options. And the BCLC staging system also, apart from looking at the size of the cancer and the number of tumours, how far it's spread, also includes the liver function, because most people have liver disease, but also the performance status of the patient, how fit or active they are. Whereas with cholangiocarcinoma, we use the traditional old TNM staging, how big is the tumour, has it spread to lymph nodes, has it spread to metastases, which doesn't really take into account these other aspects. So the epidemiology, so just to show on the left is the global epidemiology of HCC, and right, cholangiocarcinoma. And really the highlight of this is to say that these cancers are not actually that rare. As Abid said, if you lump primary liver cancer together, particularly HCC, it's actually the third commonest cause of death in humans on this planet from cancer. But really the maps are to show that there is geographical variability. There are countries where liver cancer rates are particularly high. And this is deemed, certainly for HCC, we can link this to certain risk factors like hepatitis, like viral hepatitis, for example. In Mongolia, in Egypt, a high rate of hepatitis C, which is actually iatrogenic, caused by medicine, by the WHO's schistosomiasis treatment program. So there is global variability in terms of these cancers, and they are increasing. So this is the epidemiology of primary liver cancer in England, showing, so the red line, female rates and blue male rates. Most primary liver cancer, HCC, occurs in men, but certainly, and with cholangio, it's more a gender equitable distribution. And you can see that over time, the average number of new cases is going up. It does increase with age, but actually, a significant amount of patients, around a third at least, are under 65. So it's not really just a disease of the elderly at all, and we are seeing it increasing in younger and younger people. Now, Abid did allude to this study from HCC UK, where they said that liver cancer deaths had increased in that decade in England, but 38% were actually intrahepatic cholangiocarcinoma. So this goes against the narrative that most people in the world are taught. Most people in the world are taught primary liver cancers, 80%, 90% HCC, and then there's the odd bit of cholangio that pops up. Actually, that's not the case. Cholangiocarcinoma is around 40%. Intrahepatic cholangio is around 40% of all primary liver cancer in England, and I suspect if other countries really looked properly at the data, properly looked at it, they'd find that a lot of those cancers that they're calling HCC are not HCC, are actually cholangiocarcinoma. So this is really interesting stuff. So for those of you who don't know, there's something called the Get Data Out program, which is run by the National Disease Registration Service. And this data is accessible to everyone. And it's really good stuff. So they produce the numbers of cases, incidence of cases. So this is their data from 2020. So how many cases of liver and biliary cancer were there? 7,766 in 2020. Then you split it up into different types. And then you'll see that there were, in 2020, when you break that down, there were of this 7,766, there were 2,792 cases of HCC. And then if you look at liver and biliary cancer, how many cases of cholangiocarcinoma were there? 2,706. It's really not very much difference. So maybe 2020 was a weird year, maybe they just got their data wrong, maybe they just, their Excel spreadsheet had a glitch. So let's look at, so the latest data they've now produced is from 2022. There is a lag of about 2 or 3 years. And this is 2022's data. So how many HCCs were reported in England in 2022? 3,175. How many cholangiocarcinomas? 2,973. It was almost 50-50. And yet this data is out there, it's publicly available. I've gone on about this for years. I've published papers on this, and there's still this perception that, oh, it's all HCC. HCC is a very important disease, don't get me wrong. I treat HCC patients passionately. But let's call it what it is. Let's not make cholangio the orphan disease anymore. And the data's there. Another interesting similarity between cholangio and HCC is that there is a geographical distribution and differential rates around the country. So most epidemiological studies say, rates are going up in the US or in France or whatever. But not many places have actually looked at the variation within a country. But for both HCC and cholangio, we have in this country. So, for example, this is one of the publications that we got that Helen alluded to in her opening talk. You can see here between 2001 and 2018, this is the incidence of mortality, as the incidence of cholangiocarcinoma, and on the bottom graph, the mortality. And this is a map of England, split by the 21 geographical cancer alliances in the country. And what this shows is two things, really. One is that overall, the map's got darker. The darker, the higher the incidence. That's the first thing to notice. And the second thing to notice is that some places are darker than other places, significantly darker than other places, particularly up north. So there's differential variability. And this is from Burton's paper looking at the same thing for HCC, again showing that there's variable distribution of cancer around the country. And I'd encourage other countries to consider doing this work, because that might give ideas, links, hints towards potential risk factors that we don't know about, which is what this sort of study leads to. The other common thing between cholangio and HCC, and sadly many diseases, is that it's not equitably distributed in terms of deprivation. So the mortality rate from cholangiocarcinoma increases in the most deprived in society, as you can see by this top line here. And similarly, that's also been shown in HCC. So the social determinants of health are associated with mortality for both liver cancers, HCC, cholangiocarcinoma. So risk factors. So Abid spoke about risk factors for HCC. So the vast majority of HCCs occur on people who've got a history of chronic liver disease, cirrhosis particularly. If someone has cirrhosis of the liver, their annual risk is somewhere between about 1% and 8%, depending on how many risk factors they have and what they are. And because we have a group of people who we know are at high risk of HCC, that supports the idea of doing surveillance, which is done by a 6-monthly ultrasound scan and a serum AFP. This is something that is being debated as to whether that's the best way to do it and whether everyone needs it, but still every international authority in the world recommends doing surveillance. And it does, and knowing what causes HCC does give opportunities for prevention. So, for example, treatment of hepatitis B, C, lifestyle modifications, etc. I mean, I was talking about this with Harry and Noel and Gillian yesterday in the bar about how, all this, technology is coming, but it's not really having an impact. But actually, a lot of the technology, if it was actually applied, would make a huge impact. So today, we could wipe out, for example, hepatitis B in a generation. Right? If everyone was vaccinated for Hep B, if every pregnant woman was screened for it and treated for it, you could wipe out the technology is always there, has been for years. We could wipe out Hep B in one generation and almost halve HCC cases. It's already there. In cholangio, yes, we've got this molecular profiling, but if every single patient was properly assessed, properly molecularly profiled, had access to treatment, it would have an impact on survival. So the technology, so society doesn't always keep up with technology, and there are socio-political reasons for that, which I could talk about for hours, and maybe I will if Rahini doesn't turn up soon. So risk. What about for cholangio? So there are recognised risk factors for cholangiocarcinoma. So any sort of chronic disease of the biliary tree, cystic disease, stone disease, PSC, primary sclerosing cholangitis, which is the commonest known predisposing cause. And also, interestingly, the risk factors slightly vary depending on whether the cholangiocarcinoma is inside the liver or outside the liver. But interestingly, over the last few years, we've now come to recognise that cirrhosis and chronic liver disease is not just a risk factor for HCC, but actually is a risk factor for cholangiocarcinoma as well. And that's been well published in the literature now. But the big difference is that the majority of patients with cholangiocarcinoma have none of these risk factors. It really just comes out of the blue, totally sporadic. And that's something that is different to HCC, and that's something that we really need to drill down into. So surveillance for cholangiocarcinoma. So we've mentioned about surveillance for HCC, but how do we do surveillance in cholangio? Well, we don't do. There is no established, agreed, proven way to do surveillance for cholangiocarcinoma. Mainly because most people don't have any risk factors, so you can't survey the whole global population for something that is in most people never going to happen. But we do know who the highest at-risk individual group is, and that's in the Western world, that's PSC. In the Eastern world, in Thailand, it might be people with liver flukes, but in the Western world, it's PSC, this autoimmune disease that causes chronic damage to bile ducts. And these patients have a lifetime risk of 35 to 40% of cholangiocarcinoma. So surely this is a group that we should be screening, you'd think. But the problem is, how do we screen for them? There is no proven way to screen for them. But there is suggestions from the literature, from cohort retrospective studies, that if they are screened or investigated, then maybe it might be beneficial. So, for example, this study from the Mayo Clinic just looked historically at people who were having regular imaging, and those that had an overall increased survival compared to those who were not getting any regular imaging. So over 77% of patients with cholangiocarcinoma diagnosed by regular imaging-based surveillance were asymptomatic, which is another important reason to think about how we do surveillance for these people. And cholangiocarcinoma patients who are identified through surveillance had higher rates of curative treatment compared to non-surveillance. And then in a study by Palak Trivedi, colleague and friend in Birmingham, it was a UK-based study of 2,500 PSC patients, which showed annual surveillance imaging was associated with a reduction in biliary tract cancer. But these studies are retrospective. No one's done a trial. There's only ever been one trial on HCC surveillance, and that was many years ago and has not been repeated since. Okay. I think
you have plenty of time.
Yeah, okay,
plenty of time.
Fine. Okay, so what about local regional treatments? Local regional treatment means things like ablation, embolization, TACE, CERT. Certainly this has been established and been used in HCC for many years. And cholangio is sort of playing a bit of catch-up with this, but there's evolving data on local regional treatments for cholangiocarcinoma as well, and more evolving data on radiotherapy for both these cancers. As I said at the beginning, surgical resection is usually the best chance for cure, but both these cancers, even if you resect them, and the pathologist says, yep, you've got the whole cancer is out, the recurrence rate is pretty high, 40-50% within a few years. So is there any adjuvant therapy? Anything that you can give to prevent or reduce that risk of recurrence? Well, in cholangiocarcinoma, the BILCAP trial led by John Primrose, who's going to talk about this a bit later on in the conference, established that capecitabine may potentially reduce the risk of recurrence. But for HCC, at the moment, there is no adjuvant or neoadjuvant therapy to reduce that high risk of recurrence. And that's something that hopefully we can find for HCC at some point, because there are multiple trials ongoing. That's the difference in the survival curves. The top group had capecitabine after resection, and the bottom group didn't. And you see how they separate out. Liver transplant. So liver transplant has been established in HCC for many years, but under strict criteria. The Milan criteria, which means that if there's one cancer up to 5 centimeters or 3, but none of them are bigger than 3 centimeters, you can transplant and expect a good 60-70% 5-year survival at least. And over time, the Milan criteria, I think, came out in 1999, and people have extended these in various studies. But transplant for HCC is established and has been done thousands of times globally, whereas in cholangio, it's historically very rare because the survival post-transplant was always poor. There was a high risk of cancer recurrence until the Mayo Clinic re-looked at it. And when I said unintended, sometimes people had a transplant for HCC, and then when the liver was taken out, actually there was no HCC, it was cholangiocarcinoma in there. So now we are re-looking at transplantation for cholangiocarcinoma, and Professor Doug Thorburn is going to give us an update later in the conference about how we go from there. Okay, I'm just going to, last few minutes, just talk about systemic treatment, because this is interesting. So immunotherapy, immune checkpoint inhibitors, are now used as first-line systemic anti-cancer therapy for both advanced HCC and cholangiocarcinoma. And although cholangio has played catch-up with HCC in many things, in this area, I would argue that it's probably ahead, and it's something that maybe HCC could learn from, in that we have, for some reason in cholangio, a lot more potentially targetable systemic therapies based on specific molecular alterations. We heard a lot about this yesterday, and there's some more talks on this coming through. But we now know, as we've said earlier, that there's 3 anatomical subtypes of cholangiocarcinoma. They also exhibit different types of mutations that drive the cancer in some of them. And this has been the timeline of drug development in biliary tract cancer, which is really quite exciting in the last 5 years. Certainly, 15 years ago we had GEM-CIS, on its own, but now we have durvalumab in addition to that as established first line based on this trial, where if you added the immunotherapy durvalumab, you got improved survival in compared to the traditional first line. And this is very exciting, the molecular profiling of cholangiocarcinoma. For example, if you look at IDH1 or 2 mutations, these cause hypermethylation, which causes DNA damage. This study suggested that ivosidenib, if you use that on patients who have this mutation, targeted therapy improves survival. Pemigatinib, we heard a little bit about yesterday, for patients who've got an FGFR inhibitor, a second-line treatment can be very effective. And it was a bit of a fight, but we did manage to get NICE to approve that eventually. And this was a study on pemigatinib, the FIGHT 202 trial. I'm going to skip these because we are going to come back to that. But I really just wanted to emphasize the molecular classification of cholangiocarcinoma is quite amazing. And in the FLIGHT 202 study, potentially clinical actionable alterations were identified in 44% of patients. And so it's key for patient selection and optimal management of cholangiocarcinoma. And when I last looked at the ongoing trials of biliary tract cancer, there were around 50 looking at targeted therapies. That was about, I think, a few months ago when I last looked at that. There may well be more. So it's a very exciting time in cholangiocarcinoma, and I hope we can achieve the same in HCC. There's a scale called the SCAT scale, which is the scale for clinical actionability of molecular targets. So if you find a molecular target, if it's SCAT 1, that means that it's ready for routine use. If it's SCAT 2, it's investigational, etc. And this table from the ESMO guideline found that all these potential mutations have varying prevalence, but IDH1 20% with an SCAT 1A 1B. So really, a lot of these mutations are ready to be investigated or trialed, or indeed have systemic therapy. And that played out in the ESMO clinical practice guidelines summary in terms of saying, get mutational profiling done and give targeted therapy when you can. This leads me on to the SAPPHIRE ABC10 study, but John Bridgewater's going to be giving a talk on this. And it's an exciting trial because the idea of this trial is that at the beginning, you identify the mutations. Then you give people the standard treatment, and then those who progress or after a certain period of time, if they've got an actionable mutation, you then put them in a trial to have that treatment. It's a very exciting new way to do a trial, but and we're very fortunate that we have leadership in cholangiosystemic treatment in the UK, global leadership. And these are the sorts of alterations that are going to be looked at with the agents that are ready to be given in this trial, depending on the mutational profile. But John's going to give a separate talk on this. And just my last slide, really just something I just want to throw out there is that maybe we need smarter study designs for these relatively rare cancers. The model of everything's got to be a randomized controlled trial of hundreds of patients with the new therapy versus the standard therapy, even though the standard therapy has been there for thousand years, isn't, I don't think, very attractive anymore. I think we need to be a bit smarter. If you're a patient with a cancer, you don't want to just have a placebo or the standard therapy, I would guess. And maybe one of the things about AI, there will be a talk on AI, not by me, but maybe we don't need control arms. This is a very controversial statement, but maybe we don't. Maybe we can have AI-generated control arms and say that if you had a control arm with the standard treatment, this is what you'd get. So everyone can get a novel therapy. Maybe. It's a very controversial thing to say. Might get sacked before the AMMF's next meeting, but it's something to think about. Okay, just want to thank, firstly, my patients, the AMMF, of course, and the people who've given me funding, and all my research fellows, and John and Chiara for some of the slides I've used. So thank you very much. I hope that's been interesting.